Kamala Reddy garu. Both
Yeah,
of them
I know. I know Gurumurthy Reddy garu. గాజువాకలో తెలుసమ్మా నాకు. నేను గాజువాకలో ప్రాక్టీస్ చేశాను.
నేను వాళ్ళ ఆకరమ్మాయినండి.
ఓ నైస్ అమ్మా, వెరీ నైస్. Nice to see you.
So Dr. Uday Kumar, let me formally introduce her. Thank you all for joining us. Thank you all for joining us. Tonight's speaker is Dr. Madhavi Gurusu, a graduate of Andhra Medical College. She comes from the 1992 batch. She has been increasingly recognized as an active hematologist oncologist in Connecticut. She is the site director for the Hartford Healthcare Northeast region and also an assistant clinical professor at University of Connecticut. So I have spoken to her a couple of times, and as we encountered more and more difficult situations that we are all hearing from the way patients are being managed, we thought it would be good to have her address the hematological consultations, for this lack of a better term, as she gets called on COVID patients. Now we have, Dr. Gurusu, we have already spoken a couple of times, but I think so many questions came up on this topic, the coagulability, hypercoagulability, and the microthrombi and the macrothrombi, blah, blah, blah. So our crowd is eager to listen to you tonight. You can begin any time, and I will handle your PowerPoint.
Sure. Thank you. Thank you so much. Well, it's a pleasure and honor to be speaking and sharing what I have learned with the esteemed AMC colleagues. Thank you so much for having me, Dr. Kairam and Dr. Sudhakar Garu. Thank you so much. So listen, Dr. Kairam will be bringing up the PowerPoint, but I would like to make it, please, humble request that we need not follow the PowerPoint slide by slide. By no means I'm trying to, I'll make it anything boring. I want this to be a very fluid discussion. Please raise your hand. I'm sure I'll be entrusting Dr. Kairam to keep an eye about who is asking a question. Please stop me. We'll have an informal discussion. This is by no means anything like a didactic lecture or anything. So let me, when I put a couple of slides today, let me just share the thought process behind that. Even though you will be seeing the main heading as a COVID and hypercoagulable state, I have included later in the slides about COVID and cancer. And what I mean by that is, again, of course, me being an oncologist, how can I not talk about the cancer part? So about the vaccines and in patients with stem cell therapy, the CAR T cell or whatever, how we are doing and all. So that is the kind of the thought process that I had. And thanks to Dr. Kairam, who has given me a little bit feedback about what the, I won't use the word burning questions, but kind of what were more intriguing, the questions about the hypercoagulable state in the COVID patients. Please, Dr. Kairam, can you please proceed to the next slide, please? Okay, so how can a thrombosis discussion be complete without the mention of the workhouse triad, right? So as we all know, the center point being the thrombosis. So the inciting events are the vessel wall injury, stasis, and the hypercoagulability. This ultimately results in the thrombosis. So if for a minute we are talking about taking the example of what's going on in the COVID patients. So there are a couple of theories and the evidence, so to speak, but basically the COVID virus has the capability of the direct endothelial invasion. And as we all know, the inciting event for any kind of clotting process is the endothelial injury. There could be a cascade of events happening, the exocytosis, the release of the prothrombotic factors, you name it, then the platelets coming onto and further a clot formation, but the direct endothelial invasion. Then comes the complement mediated injury. So the way that I explain and I conceptualize what this complemented mediated injury is, if we remember from our microbiology, the textbook, we have what the classical pathway, the alternate pathway, and the lectin pathway, right? There are three pathways of how the complement gets activated. So why do we have the complement, right? We all have the innate complement system that is a mechanism of protecting us from infection, anything other toxin. So what this is happening with these spike protein from the COVID virus is it has the capability to activate the alternate complement pathway. I didn't want to make it boring showing you all that how the membrane attack complex forms. But if you remember the sequence of the cycle where the complement pathway gets activated, then the C3, then the C5b, and ultimately it's the C5b to 9 is the membrane attack complex, right? So what is happening in this membrane attack complex is literally poking walls into the cells, be it an endothelial lining or the platelets, and this results in the release of the inflammatory cytokines, the clot formation and all. So anything that goes beyond, even though this is meant to be a protective mechanism, if the overwhelming activation is ultimately resulting in the clotting cascade, that is one theory there. And in our ICU patients who have inevitably probably need the intravascular catheter, that is another mechanical device which is activating the endothelial injury. And as we all know, there is a tsunami of the cytokine storm that is happening in the patient's body, right? Again, once again, this is all meant to be a protective mechanism, but which has gone totally out of control. And the NETs, which are the neutrophil extracellular traps, and the elevated prothrombotic markers. Again, so I did not put in too much of what those prothrombotic factors are, but in the studies, what they have shown is that elevated factor 8, again, are D-dimers and the fibrinogen part. If you, for a minute, if we think about why is the morbidity and mortality higher in obese patients, I mean, if we think about it, we all know that the factor 8 levels are kind of increased in our obese patients. Those are all, is that the reason why the obese patients have higher incidence of the clotting part and as a result of morbidity and mortality? Probably. But that's one other thing. And the transient antiphospholipid antibody positivity. We all know that, again, it's not just a lupus anticoagulant. Remember, what are antiphospholipid antibodies, right? We have a couple of categories. One is the anticardiolipin antibody, the lupus anticoagulant, beta-2-glycoprotein, phosphatidylserine antibody. And these transient antiphospholipid antibody positivity, is that also playing a role in patients having the clotting part? Probably, but this is what is happening in our clotting part. So any questions so far?
For a moment, the audience is muted. If somebody wants to ask a question, they have to unmute themselves. Please proceed.
Thank you. So the next slide, please. The purpose of putting this slide was to give the spectrum of the clot formation. Well, as we all know, it's not only in your acutely sick intensive care unit patients. It's happening even on your floor patients too. What do I mean by floor is these are not that acutely sick, be it in the step down or your regular floor patients. It is happening even in your outpatient setting as well. And as we all know, the COVID-related clotting is not partial. It has no discrimination, whether it is venous, meaning your patient could present with, of course, as we all know, a DVT, a pulmonary embolism, or it could be an arterial. Of course, it can be an MI, it can be a stroke, it can be the microvascular thrombi. It, again, what the, unfortunately, the autopsy findings of those lungs and what we are seeing, the microthrombi. So be it the macrothrombi, microthrombi, arterial, venous, whichever a clinical setting, the clotting process goes that uncontrolled. Next slide, please. So where I wanted to touch base on a couple of, again, not to overwhelm ourselves with this trials about what is the role of the prophylactic versus treatment doses versus intermediate dose. It's a little bit interesting paradigm shift, so to speak, in all our learning. And again, if any one of us claims ourselves as a COVID expert, I think that's the biggest baloney, because nobody is. We are all learning in this together. But interesting part is that during this March, April of 2020, when we were all learning, there used to be a much more, I won't use the word bias, but more so no, if there is, you are better off giving patients treatment doses of anticoagulation. I do not think that's totally the right way of at least what we have now with these, a little bit of the clinical trials going on and the studies part. So again, by no means I'm trying to say that this is relevant for our treatment patients, meaning that if a patient, of course, has a DVT or a PE part, of course, you have to treat them with the treatment doses. But in those patients whom we are talking about prophylactic doses, really does an intermediate dose. So what is an intermediate dose? Remember, what is the treatment dose if we are talking about something like Lovenox, which is enoxaparin, which is a low molecular weight heparin? You give them 1 mg per kilogram BID, right? That is your treatment dose. Whereas a prophylactic dosing on a floor patient, or even in a, if it's a prophylactic dose, it's what, 40 milligrams subcutaneous a daily basis. Whereas this intermediate dose is 1 milligram per kilo once a day part. So there are a bunch of studies I was able to see. Not all of them were peer reviewed, but there are ongoing studies, some preliminary data part. But there were few didn't come exactly into the peer reviewed journals, probably, or not as much known because the results did not reach statistical significance. But I felt like I should put in the schema, which will be the next slide. Let's not go into that yet. But this inspiration trial, where it was a little bit clean done study, the bottom line was that these were the patients who were admitted to the ICU with COVID-19 and who received intermediate dose of prophylactic anticoagulation compared with the standard dose prophylactic. That did not result in a significant difference in the primary outcome of the, which is the outcome is what? The venous or the arterial thrombosis, or treatment who were on an ECMO or mortality part. So the bottom line was that these results make us think that probably there is not much of a value for empirical use of intermediate dose prophylactic anticoagulation in unselected patients. So meaning that maybe we should be okay with the 40 milligrams dose part, but remember, all this is your clinical judgment, right? Let us say if you are in the ICU scenario, I'm not an intensivist, but many of you who are in that, in the middle of the night, you are monitoring the patient, and probably if there is no immediate way for you to be confirming it, whether with a CT angiogram, whatever, that the patient has pulmonary embolism or anything. But this patient with no other clinical evidence of ARDS or CHF, whatever that could be the differential diagnosis, that's not the reason, but your patient's pulmonary status has changed and you are so much clinically in tune that this could be a new PE, then of course you're going to treat them with treatment doses, and you're going to dial up the dose of the anticoagulation. But in other scenarios, what I thought like it might be a worthwhile thing to kind of, more is not always better, is my point. Next slide, please. So this is a kind of, again, this was in the Journal of Thrombosis, I believe. Again, the intent is not to go into all those micro details part, but how the randomization was done between the intermediate dose. I mean, they were, again, a later double-blind randomization. But again, as I said, I went from the conclusion now to the schema part, but to kind of give you an idea about how the study was done. And standard dose anticoagulation is still the standard unless the patient needs the treatment doses. Next slide, please. So here I put in just few pearls, like just this is a casual conversation part. What exactly did I mean by saying that treat the patients, not the lab values, use clinical judgment and all? See, if the patient has elevated, D-dimers or the fibrinogen part, and again, how to a little bit differentiate between DIC versus what the coagulopathy, what's happening with our COVID patients, again, to use clinical judgment. So if there is otherwise no other indication for a patient, once again, going back to the, probably I can correlate with the example of the same treatment doses of anticoagulation versus prophylactic doses. So use your clinical judgment if the patient is that high risk and the clinical scenario warrants, not just by the lab values that you go ahead and give the treatment doses, those kind of clinical judgment part. And few other pearls that I wanted to add was that, there is, if a patient you're monitoring on the heparin and the PTT is unusually prolonged, there has been literature to support about heparin resistance, and the better way to monitor those would be with your without the PTT, but using an anti-10A level probably. And remember the transient antiphospholipid activity part as well. Again, if there is a lupus anticoagulant, can one of the coagulation parameters be a little bit off? So use clinical judgment part, just keep those other things as well. And a little bit of differentiation between, again, I'm sure we all know about, if it's a DIC part, you would have this consumptive coagulopathy, decreased fibrinogen, whereas in COVID patients, what it's happening is, even though that's all activated, the coagulation pathway and all those, we don't see the decreased fibrinogen part, rather elevated fibrinogen, because rather than that, the scale is obviously towards more of the clotting side than the bleeding side. So a few other things I thought, based on what Dr. Kairam has suggested, that few questions that came probably in the past couple of the discussions part. And again, if a patient is, if your patient is a pregnant patient who is hospitalized for severe COVID-19, you treat them with what you would have done, like with the prophylactic dose part, and not necessarily that you have to send the patients on anticoagulation to home, unless the patient has a previous condition for which the patient was on whatever. So we all have our own patients, right, that who had miscarriage or DVT during their prior pregnancy, and this pregnancy, the second consecutive one, anyhow you were planning on putting them on prophylactic doses. So per se, the COVID-19 should not be the indication, is what the suggested literature part. And let us say if you have your patient who is pregnant with and who has COVID-19, who doesn't warrant hospitalization for the infection or mildly symptomatic, again, there is not a literature to support that you have to routinely give them anticoagulation. And we all know, well, I see that somebody had put in the comment that we are doing, we'll come to that in the chat section. But closer to the, if your patient is closer to the delivery of your, the patient is close to, again, because if they need any neuraxial anesthesia and all, you are better off taking the, putting them on the unfractionated heparin, versus if they were farther out, again, no brainer that you use the low molecular weight heparin. Dr. Kairam, do you want me to take the chat question now versus just proceed and then come to this? Or again, I didn't see the entire question.
Since you are spending time on pregnant patients, you might want to finish that and then we'll go to the chat box.
You bet. Okay, next slide. I think this is, yeah, I think those were, I felt like we should have the discussion. Again, these were all just meant to like pillars of thought to the discussion, and then we take it from there. But, so we can have a discussion now.
Yes, okay. Dr. Manoj Patruni, who has put in that question, is currently involved in running the large COVID hospital inside KGH. He is frequently a contributor here. And he's asking a good question as doctors, are we doing a favor by prescribing anticoagulants invariably as a prophylactic dose, but not as a part of treatment for everyone? My doubt is, are we doing any harm prescribing anticoagulant, or is it harmless and as a preventive strategy against thrombosis?
Right. So my take on that is that I think, see, the studies which have showed the randomization between the intermediate dose and the prophylactic dose, number one, they did not reach that clinical significance that you are doing the reduction of the clots, anything different in this versus the other. But kind of, yes, the bleeding complications were higher with the higher dose. So I think it would make a logical sense. Again, total understanding that this is not a patient that who has the clot. We are talking about the prophylactic part. I think it is very reasonable to consider if my patient today goes to the hospital with a pneumonia and gets admitted, invariably I'm going to put them on prophylactic dose. The same thing, I think we should be doing that to all our even the COVID patients, the prophylactic part, because they are immobilized, they have this inflammatory cascade going on. So that would be the standard practice for any of our medical patients or surgical patients after the surgical procedure, whatever, right? So I do not think it would be a harm by giving the prophylactic dose, because no, I think that's the standard medical practice that we should be giving to prevent the clot formation. Whether do we need to give them the treatment doses without a documented or clinical high suspicion to support the treatment doses? Probably that is a little bit more than what is required, in my opinion.
While you are at that point, I want to ask.
Yeah.
Okay, Dr. Anne will come in a second. Your earlier slide on the Inspiron results use the word intermediate dose. So somebody was asking yesterday, COVID produces an asymptomatic stage, mild, moderate, severe, critical. So we have been talking about prophylactic dose and therapeutic anticoagulation. The word intermediate relates to intermediate dosing or intermediate agent. What is the definition of the word intermediate?
Intermediate dosing, exactly, to be specific, 1 milligram per kilo once a day. Once again, the usual prophylactic dose is 40 milligrams once a day, right? If the patient has some kind of creatinine renal issues, that would have been 30 milligrams once a day. The treatment dose, should your patient need, that would be 1 milligram per kilo BID. That's the treatment dose. Whereas the intermediate dosing part is 1 milligram per kilo once a day, not BID part. So did that make a difference? No. And so whether you gave them once a day 40 milligrams or 1 milligram per kilo once a day, you are increasing the bleeding complications, but achieving the same results with your prevention of the clotting.
So
Dr. Sudhakar has a question, looks like.
Yeah, Madhavi, thank you. Ram Mohan, can I go ahead and ask a question?
Yes, please, yes.
Yeah. The Dr. Manoj Patra's question has not been answered as yet, because here what he was asking is about the prophylaxis when the patient is discharged. We know for hospitalized patients, we give them a prophylactic dose. We know we give therapeutic dose for those who have a thrombotic episode. But what is the question here is whether we prescribe the low dose or the prophylactic dose when the patient is discharged. That's what his concern is.
Okay, so if your patient is what we have been doing, and if the hospitalist asks me, and again, if the patient is still somewhat sick, What do I mean by that is, again, your patient is not that sick to stay in the hospital, but at the same time, you are very sure that this patient is not going to be just like that up and walking and talking and doing everything, but there would be its status, the sedentary status and all. Then I think it's very reasonable to consider something like Xarelto, which is a rivaroxaban, 10 milligrams once a day for a total of like 6 weeks or so. And again, probably most of the patients come into that category, but not necessarily all of them. Does that answer your question, Dr. Patruni?
Manoj?
Good evening, doctor. Actually, my concern was like, as Sudhakar sir quoted, it is post-discharge as well as the treatment part. Once we give a patient comes up with COVID positive to the hospital facility, as you were already as we were discussing, the prophylactic part would not do any harm. But how can we say that this prophylactic part is only necessary rather than not the treatment part based upon only the investigations? Because thrombosis can lie anywhere. We cannot say it can be a pulmonary thrombosis, or we cannot say it will be a deep vein thrombosis, which is only due to mobilization or an unmobilized patient or due to any comorbidities. So it is better we can go for prophylactic treatment for everyone, and based on the investigations, we can even go for the standard treatment protocol of anticoagulants. And then, as per many discussions, there is because of lack of data, and the doctors even say that some of them are in a intermittent state, like we can give the treatment for post discharge for 1 week or 2 weeks, or someone says that it is not required post discharge because the patient is not having any problem or is likely to be ambulatory after the treatment at home. My only doubt raises because as investigations, every part of thrombosis cannot be diagnosed as such in the hospital, in COVID care center, particularly in India, that every patient doesn't go for a screening for whether he has a thrombosis or not. So it is better we go for the treatment with anticoagulants if it is not harmful to the patient.
I think probably, Dr. Patruni, I think we are all on the same page, meaning that if I am understanding your thought process right, you said prophylaxis for patients who are in the hospital. Agreed. We are all on the same page. If in the hospital, yes, you are right, we would have probably the means and the mechanism of probably few extra eyes watching them, and you have all the diagnostic gadgets, tools to do their Doppler, or CTA, whatever. If your patient needs treatment dose, no brainer, you're going to give them the treatment dose. But let us say if the patient is probably, again, as I said, that is where your clinical judgment comes. If your patient is, and if you are not sure that your patient will be up and walking and doing everything, and you want to be careful, then that's your clinical judgment. I would say that then continuing the prophylactic dose, again, probably more so the point is that what is the dose part again. So again, the clinical scenario part, for example, again, a little bit pivoting gear here, if there's a pregnant patient who came in and with mild thing, and if the patient is going home, do we have to routinely put them on anticoagulation part? Again, that's a case-by-case basis part, but it's not like, oh, you are pregnant, you had COVID, but mild COVID, but still I'll put you on. That probably needs to be a case-by-case evaluation part. But I do not think there is much controversy about the prophylactic part. And going back to that question about if you said that, yes, in India or anywhere, if there is so much of the volume of the cases, and if it's hard for the patient to kind of report to or come into the clinical, vigilance of the physician, and if you are not sure about, that this patient will be up to speed, that's your clinical judgment. Then I would say that whether if your patient would want an injectable versus an oral, going with the prophylactic is pretty reasonable. and probably it's cost effective, again, depending on the patient by case scenario.
So if the patients are discharged and then after post-discharge and they are on treatment of anticoagulants rather than prophylactic doses, is there any standard protocol to be followed or the dosing part which is necessary until this particularly this category patient need to be treated for a week on the prophylactic dose or for 2 weeks or something like that with any standard prophylactic dose after discharge?
Right. So the easier thing would be giving an oral, right, rather than having a family member poke them every day. I would probably go with an oral anticoagulant. What I have been recommending has been the Xarelto, and what even the pulmonologists use here. Xarelto is a rivaroxaban, the oral, the anti-10A anticoagulant. That 10 milligrams, as you recall, the treatment doses are different, right? Which is 15 milligrams PO/BID for 3 weeks, then 20 milligrams once a day is a treatment dose for the rivaroxaban. Here you are doing a preventive dose at 10 milligrams per kilo. And they talk about 30 to 39 days. So give or take, it's like 5 to 6 weeks, I would say, that post-discharge part.
Thank you, doctor.
I'm actually a little bit confused with regard to continuing anticoagulant for a mild disease already discharged, gone home. I thought in the past few days I've been hearing such a patient does not need anticoagulation at home. Did I miss that Dr. Pathruni is talking about somewhat more ill patient that has been discharged? Or is it somebody that did not require therapeutic anticoagulation in the hospital? Which one should be given post-discharge anticoagulation for another 2 or 4 weeks?
I think what he or any one of us would be thinking about is, we are talking about, if we think about it for a minute, let us say, a patient won't come to the hospital if the patient is not that sick, is my take on that. And yes, I have definitely seen patients who have remarkably recovered and there was no worry about it. But there is a significant, for those patients, probably no. If they are totally, if you're not worried, it's a mild illness, they came for whatever their concern and all, and there was no other risk factors like be whatever. If you think that this is a very obese patient, hardly, even though they're doing okay, again, I'm just making up a case. If their mobility is great and no recent fracture, no recent injury, those kind of things, which you would have thought about the clotting, no recent travel. Well, if you're comfortable with that, you could let them go without anticoagulation. But if any of your, so the risk of that you are worried about the clot formation part, then I would consider the prophylactic dose. Again, if it's a treatment, if the patient has received treatment in the hospital, then we are talking about, it depends on the variation. I am definitely keeping them on 6 months of anticoagulation should they have received treatment doses of the blood thinners while they are in the hospital. Let me see. A few other questions in the chat box are, do you think anticoagulation will prevent arterial thrombosis? Do you recommend antiplatelet treatment, with Dr. Ane's question? Well, Dr. Ane, I do not think there has been much data to support antiplatelet agent like aspirin and things. And there is, again, because there is not much of clinical identifying factors that, oh, well, this could be the patient who would get more of a possibility of an arterial thrombosis versus a venous thrombosis. Going ahead with the standard thromboprophylaxis, like whatever that we are doing with the low molecular weight heparin, those kind of things, rather than an antiplatelet agent, is what standardly that we have been doing. Well, if the patient, again, obviously, if the patient has had cardiac history or a stent, or the patient has been on aspirin, of course, you continue making the risk assessment part.
So I'm trying to mute people who are speaking in between. Madhavi, Dr. Phanender has raised his hand. Dr. Phanender. Well, he might still come back. A moment ago, I saw Dr. Pilla. Dr. Pilla, do you have a question?
Sir, am I audible, sir? No?
Yes, yes, you are. Please proceed.
Yeah. So, good evening, Dr. Madhavi. This is Dr. Phanender, pulmonologist. My same question, actually, we are focusing not on the, ambulatory patients or non-ambulatory patients where there is a possibility for DVT. We are focusing on the endothelial invasion and the pulmonary angiopathy, which is a cause for the intravascular microthrombi. So in that accord, how long does that pathology last in a discharged patient or in the admitted patient, and how long we need to give a prophylaxis? That's the main question. But the people are asking, are answering in a different way. That's an non-ambulatory patient, okay, it's good, but an ambulatory patient, not required. So I am focusing on the pathology, like, endothelial invasion and the probability of microthrombi. So in that regard, how long a discharged patient can be receiving anticoagulants? That's the main question.
Well, that's an excellent question. Unless there is clinical lifetime in life, meaning in vivo measurement of these procoagulants and all that, I think it's hard for us to exactly say. But in those patients, again, where did this 6 weeks or 31 to 36 days or 39 days come from? And even if a patient with if a patient had a clot, I know that that's not your question, but if a patient had a clot, it's not, why are we giving the 6 months of anticoagulation? If you think about it, it's not per se only to, it's not to dissolve the clot and all, right? Obviously, we are doing this to prevent the further insult that's going to happen. Yes, so I think, right. So I believe this is a little bit of an arbitrary number that has come, because what is the difference between 5 weeks versus 6 weeks? You pick your choice. But I would say that is kind of an arbitrary number. I won't probably get focused on, oh, let me give only 2 weeks, that kind of a thing. If you think that your patient is at risk, again, be it whatever, ambulatory, but not have other risk factors or those kind of things, I think these are kind of the in the semi ballpark, I would say, like the 6 weeks apart. But is there any particular a study that has shown the exact difference between 2 weeks versus 4 weeks versus 6 weeks? I'm not aware of that. That would have been lovely if we could say that. But I would say that the 6 weeks part, it sounds reasonable. And if the patient had a clot, again, to give for like 6 months, if a patient had a pulmonary embolism, if it's a below knee DVT, those are, again, we are not going to go into that extreme weeds of discussion part, but those are the things that kind of which makes me obviously think that this is not like a one-time snapshot thing, that inflammatory cascade is going on. And the downstream effects are also happening and things. Yes. And we all know that we are more worried about the mortality of when the clot recurs. You know, those kind of things. Yeah.
Yes. That's it. That answers my question, because I'm worried about the, clot recurrence or any events like related to thrombosis, like the MI or the vascular strokes. Right. Thank you very much.
Thank you.
Dr. Anne has a question.
Dr. Madhavi, thank you for taking my call.
Sure, Dr.
One of the issue that I'm facing is people that are developing acute MI, acute CVA, within a week after the discharge, or within a
Dr. Anne, could you speak up a little bit, please?
Yeah, within a week after the discharge, having MI or cerebrovascular accidents, we're frequently seeing them. I mean, not as frequently as we're talking about pulmonary embolism, but definitely their mortality, we're seeing patients recovering very well with this disease, and then suddenly having an acute MI and acute CVA. That's number one. Second thing is we know now a lot more literature coming out, as the doctor mentioned, Dr. Faninder mentioned before, with the vasculitis, where we're seeing more now with the neutrophil extracellular traps, which is probably having a significant etiological factor, or probably the possibly resulting in the vascular thrombosis, especially the microvascular and arterial thrombosis. So what do you think about the thoughts, how to prevent that or how to address that these patients?
Well, I would probably look into the very case-by-case basis, Dr. Ane. Have I encountered anything role of antiplatelets as a prophylaxis? Honestly, no. Probably, again, if not, we would have been talking about that as a standard thing. So then where do we incorporate this antiplatelet agent part? Again, are those the patients? If this was kind of with no other risk factors, no metabolic syndrome, no other previous or family history of cardiac, those kind of vascular kind of the ominous vascular history, if that is your patient, I don't think it is unreasonable, but there is a lot that goes on into if the patient is already on an antiplatelet agent, that's not what we are talking about. If this is a patient with no prior cardiac history, not on aspirin, I believe we should be treating them with low molecular weight heparin, like what we are doing. But if the patient, and also think about it, you are adding true COVID is clot rather than bleeding. We all know that. Even having said that part, it's not just an easy thing to make ourselves feel comfortable to throw another medication which would increase the bleeding risk. So I would probably say that, you know, if it is a patient whom you are really worried about, for whatever be the reason, okay, this patient had previously undetected peripheral vascular disease, and now you have figured that this is a patient has, or something during the hospitalization that must have triggered us to think that this is not just an venous thrombosis risk, but an arterial thrombosis, then considering an antiplatelet agent, I think it once again goes by the case-by-case basis. But the studies I have seen, though, are where they have looked into aspirin versus the low molecular weight heparin. I think there's no controversy there that these low molecular weight heparins are better. But are they better in preventing even an arterial clot part? That of the micro dissection part I haven't seen that required addition of antiplatelet agent, but it seemed like there was when they talk about the prevention or the decrease in the incidence of the clots, they're talking about the arterial and venous with the current heparin related in that family of the medications part. And so I would totally think about this, at least in my opinion. I would reserve the use of antiplatelet agent as a case-by-case basis, Dr. Rane. But again, if there is more that you have seen the literature, that would be very, very awesome for us all to learn. But at this point, I would say case-by-case, I would say.
Yeah, and one more follow-up question, Dr. Ram, if you permit me.
Yes, of course.
All right. One of the problems that I'm facing is in the last 2 weeks, I have at least a half a dozen patients that were already on the low molecular weight heparin, not only the low dose, it's even the medium dose of low molecular heparin, improved respiratory wise, and almost about to discharge from the ICU, the night developing 1 patient with a CVA and 4 patients with acute MI. They're already on the low molecular heparin for at least 1 or 2 weeks. They're all between 50 and 60 years old, and they're all healthy. They do not have any predisposing factors like cardiac problems or anything. On the top of it, we are seeing most of these patients that we have diabetes. You know, the mortality is high in diabetes, and these people are metabolic syndrome. So my question is whether these patients warrant to be prophylactically treated or preventatively treated with the antiplatelet agent along with low molecular weight heparin.
Well, it absolutely makes sense. Probably in hindsight, we are all 2020, but do we have any kind of probably this is the time for a need for us to do some kind of series or chart evaluations to see who are those patients who would kind of give us the indication, maybe something like a risk score that needs to be done for these patients to indicate the addition of the antiplatelet agent as well. I think that would be a very brilliant way of looking into, if it hasn't been done, about which are the patients, looking back and saying that what could be their risk factors, that if we could come up with a score to say that these could be the patients who would benefit. Probably that is how I would use that opportunity.
Thank you.
Dr. Pilla, do you still have a question?
I just wanted to clarify, am I audible? Yes.
No, louder.
Okay. I just wanted to clarify I'm from the OB service. I just wanted to clarify about the pregnancy and COVID. Majority of my patients in the country, we saw mild diseases and we did not require any admissions. For the patients who were admitted, majority of them had moderate disease and we treated them with Lovenox. Lovenox is to decrease the nursing services going into the room. Just once a day, prophylaxis is what is recommended according to the American College guidelines. And when they are discharged home, the newest recommendation is not to give them any anticoagulation. I just wanted to clarify. And for severe disease, of course, they will be on Lovenox as long as they are in the hospital until they are discharged. And those patients are also not sent home on anticoagulation. Thank you.
Dr. Pilla, I think I totally agree with you. Again, I'm not an OB, but these are the times when they consult us, and that's exactly whatever that you said are the mirror image of the slide that we discussed a while ago. I think you are 100% on the mark with the standard, up-to-date recommendation. So I would totally agree with what you said.
While we are on that point, as far as continuing prophylactic anticoagulant at the time of discharge, should they be using elevated D-dimer values? Asked Dr. Kurmanath.
I would not. Again, more I read about this, it is your look at your patient is what I would say, probably, rather than the lab value per se, or probably you should look at both. But the D-dimer alone probably should not be the reason for your clinical judgment, is what my take on that from what I read. And together with your patient's clinical scenario, that's a totally different thing. But if you're otherwise, your patient is good, based on the D-dimer alone, those anticoagulation decisions, you might have to think twice.
Thank you. Dr. Shyam Prasad Mallampalli, who is a regular participant on this panel, is very quick. Even during the meeting, he looks up 3-4 references and he puts up a citation. But all of us can't read them so quickly. So Dr. Mallampalli, if you promise to summarize recommendations that we could use or engage Dr. Gurusu in a question, please proceed.
Sure, Doctor. Hi, Dr. Gurusu. How are you? So, thank you so much. Your presentation was very helpful. So we've been like going back and forth in regards to the anticoagulants in the COVID situation. About the post-discharge, the article that I put in is it's a registry that was recently published in like May, which is last month. Basically, it's more of an observational data. What they found was out of the people, so there were like a few people that used post-discharge prophylactic anticoagulation, the Xarelto, I think that you were talking about, the 10 milligrams daily for, I think they used for 39 days, something like that. And they found that it did decrease the post-discharge VTE incidence, and the bleeding risk was considerably low in those people. But again, it is an observational study, so they left it to the doctor's discretion on who should be getting it. And the reason I put the study out is there are multiple scoring systems, like you said, and in that registry review article, there is that improved DD is one thing that they used, and also like there are multiple other risk factors that were listed. So just for a guidance for people who might be discharging people with COVID, in terms of who might be benefited with this prophylactic dosing, this might be helpful, I think.
Thank you.
If you have any experience using this risk score or the improved DD or anything, you can tell us about it.
Sure. I think the last time I reviewed that was, in fact, this study is also cited in the ASH, which is American Society of Hematology guidelines. And I didn't use it recently, but it is quite familiar about the data points like what you mentioned about it. And I believe, again, it's the together of the clinical and the objective data together rather than, unless the paper, as far as my memory goes, I don't think it's totally the lab data alone. I could be wrong, but as far as my memory serves, it's a conglomerate of everything together. Right, Dr. Mallampalli?
Yes, yes, doctor. It's not just the lab data. It's both all the past medical history, as well as the clinical presentation, as well as the lab data together combined. And for this is for people that were discharged and then, admitted and then discharged, the post-discharge prophylaxis.
Dr. Gurusu, given your background and connections to Andhra Pradesh, you probably have been getting consultations and questions from AP in the last 6 weeks. Is there a message that you can give to the 240 doctors on the screen? What you think they should not be doing, and what egregious practices you have seen, and how we could use this platform to say, guys, please don't do that. I am desperately listening to all kinds of questions nowadays because so many outside of the guidelines treatments are being given. So you have some experience.
Well, you are asking the wrong person. Why? My humble statement for that is, I think you guys are doing such outstanding job. Come on, no, it is, I don't think, at least the physicians who are here, the type of the knowledge exchange I hear and all, you guys don't need anybody new to tell you something new. We are all here having a discussion back and forth. I would totally applaud you for what you are all doing. No, I humbly would say no to the answer. I have nothing to say what you're doing wrong. Well, we all have those things as such to say that, there is one thing I will tell you, having said that, but talking very objectively, all the cocktails that we have seen, if there is no standard data or EUA for that emergency use authorization, those I might be hesitant in throwing whatever that you people say in the desperado at the patient's part. Again, by no means I'm an expert to talk about what the different type of medicinal non-allopathy treatments and all, but again, I would stick to the guidelines. I would stick to the science and say that, yeah, I truly believe that steroids do their work in the doses that they're recommended. You bet, of course they do. In the early treatment of patients, high titer convalescent plasma, does it help in high risk patients? Yes, I think it does. Does neutralizing antibodies given in combination to neutralize the target spike protein, the antibody part? Yes, I do think so. Again, is there much data about remdesivir? Probably not. I mean, it's not like it changes between day and night part. But again, that is probably not an unreasonable medication. But those other things, honestly, I do not have much depth of knowledge about those things. And my honest and humble feeling is that probably it's not because of anybody has any malintention to, but at the same time, that desperado, that when people are throwing things, that is where we need to believe in science and say that let's stick to the evidence based rather than going with our emotions part and giving whatever that we can. But I think you all are doing an awesome job.
Thank you. In fact, when I asked that question, I asked a little bit inappropriately, in the sense, this nightly panel was convened when we heard lots of young doctors, junior doctors, even senior medical students and postgraduates are being recruited to do acute care, both in the cities and rurally. So we thought, okay, this would be helpful for them to be current on guidelines, following guidelines. But at the same time, both from some of the community groups and even from my own direct exposure, it seems like a tremendous amount of drugs are being given, some inappropriately, some very late in the disease. You all of us have heard those. But from the standpoint of anticoagulation, as much as you have been telling us, stay with the guideline, this is the reason to do this, prophylactic, therapeutic, intermediate dosing, etc. But you have been hearing, have you been consulted on inappropriate treatment so that the people on this panel could use that to talk to other people from the standpoint of anticoagulation?
I think if at all I heard any kind of lack of clarity, even I myself, I will tell you, remember in my initial start when we started the discussion, last year around March and April, there was a lot of the balance towards probably more is better, that, you know, if you think just go ahead and treat the higher dose. I think now it's kind of, we are all settling down again, not to blame anybody, because we didn't have much of the data or studies to prove either way. Probably, I think if at all sticking to the lane of anticoagulation part, probably was there more enthusiasm for treatment doses where the treatment doses were probably not indicated, probably. Other than that, I didn't hear, I think very early on, thankfully, that we all as a scientific community didn't wait too much to jump on the wagon of anticoagulation. So in a way, I think the incidence of we are now at the luxury of discussing, oh, is it necessary, the treatment doses when it was not required? But I think it's universally accepted that yes, COVID is equal to kind of synonym to clot. So we should never forget that. I believe as long as that is an ingrained cautionary thing that nobody has to remind a particular medical professional to do that, I think we are okay. Then comes a finer adjustment about, you know, are we doing the treatment doses or those, you know, you don't have to do probably. More is not all the time better. That kind of a thing is probably sinking in more so.
Thank you. Dr. Sudhakar.
Yeah, Ramohan.
I was wondering if you had specific questions.
You know, it's again the same thing, you know, like what I understand from all the discussion is that the prophylactic anticoagulants after discharge. There are two scenarios. One is those who are ambulatory and who are not ambulatory. In ambulatory, you don't need them. If people at home, though they have gone home, but still they are restricted to bed or not so ambulatory, probably you can consider giving anticoagulation in them. This is what I understand. The third aspect that was raised by Dr. Faninder is, it is not the question of ambulation, but it is the microthrombi in the pulmonary vasculature, which needs to be addressed. That needs to be answered still, I feel. And the fourth one is, it is not the labs that we treat, it is the patient. So what is that in the patient which makes us think of providing anticoagulation apart from the ambulation, particularly considering the microthrombi in the pulmonary vasculature?
The way that I would look at,
am I clear or
yeah. So I don't, your thought process is very clear, Dr. Sudhakar, obviously, but I think, do we have that kind of ironclad distinction? I don't think so. So this is where art, again, I'm not beating around the bush, but basically it is where I don't think it is as black and white as saying that if your patient is just walking out, again, one needs to think, why the hell would he come to the hospital, he or she, if that was, you know, that a mild case. Again, the way that because just being COVID positive, I don't think somebody would come into the hospital, right? So the way that I would look at things is that looking at that entire clinical picture of what the patient has come in and when they are going, those scenarios as well. So going back to your question, well, ambulatory in the sense, I think that's a little bit of a term to kind of make us all think whether this is a patient that your risk is quite on the, or your suspicion is on the lower side. And again, at the same time, first thing is do no harm. Even though we are talking about the guidelines part and all, again, probably using it the right balance is what I would say. Not to make ourselves feel comfortable that you should give, but if your index of suspicion is high, and if there is an obese patient, and if there is, if there was kind of a previous history of phlebitis, let us say, or those kind of things part, then I think your push towards use of an prophylactic oral or whatever form of anticoagulation part will be higher. So again, going back to your question about, is it clear cut? To some extent, but not probably totally to that entire extent is what I would say. And the other thing about it's not just the labs, it is, so yes, again, it's not just the labs, it is labs plus your who is in front of you. Whom are you discharging? Whom did you treat? What do you expect that their follow-ups and all, and those kind of things part and all is what I would say. And again, if it it comes to the point that if you are as a physician, if your clinical inclination is that, no, I'm not comfortable because these are the scenarios part, I would err on the safe side, provided the risk of bleeding is not high, rather than erring on the risk of, yes, it's an ongoing inflammation part and all. But again, I think it is because one would intuitively think that, oh, pregnant patient, it's a prothrombotic state. Now we are all kind of accepting it, saying that not necessarily that you have to put patients on prophylactic anticoagulation unless there was another indication too. So I think it is, again, it comes back to your clinical judgment and along with your probably help with some lab data as well.
This question from Dr. Mallampalli, I like this question. I think a combination of steroids, anticoagulants in mild COVID disease without oxygen requirements is dangerous and can cause GI bleeding and other bleeding risks. Risks are higher than the benefits. Do you agree?
I am not sure about that. Because if you're thinking about dexamethasone 6 milligrams for daily for 10 days, right? Yes, theoretically, any kind of NSAID more so. A non-steroidal anti-inflammatory along with the steroids has increased the risk of bleeding part. True, there is somewhat increased risk, but I think the elephant in the room is the clot rather than the GI bleed. Of course, if it's a patient, if you had a patient had a history of peptic ulcer disease or esophageal varices, whatever, those kind of things. But in this particular COVID scenario part, again, in the right patient, I would probably take that calculated risk if the patient needs anticoagulant prophylactically, rather than worrying about the risk of GI bleed. Again, this is because it's this type of the disease. If it was something else, of course, we all would pick that answer. But in a COVID patient where we are all worried about the reason why the higher chance of mortality is because of the clot, I would take that calculated risk and assess it carefully. I wouldn't shy away from the steroids and anticoagulant is my point in the right patient.
Dr. Malampalli, is the trick in your question related to mild disease, not even requiring oxygen? Should we hit them with anticoagulants and steroid? Is that where you are leading?
Yes, doctor. I think I think that will be a huge population. That's we're putting a large population at risk of GI bleed, and again, without oxygen requirement, steroids are obviously not indicated. And we're seeing a lot of people that are not even requiring oxygen. They get a CAT scan, they get labs done, or whatever, without really an indication. They're getting steroids prescribed and anticoagulation, and they're also obviously taking some NSAIDs because they're having fevers, body aches, whatever. Some people think that PPI along with that will add to the mixture and the potpourri, and think that it will avoid all sorts of complications. But I mean, when you said the right patient and choosing the right patient and all that, that is obviously like the major elephant in the room, choosing the right patient. I agree that certain people are at a higher risk for clotting, like let's say obese people or people with cancers, or people who are taking other medications like OCPs and things like that. You can choose your patient, but when we say right patient, sometimes people get confused and they start treating everybody with steroids and anticoagulation, and we end up with more trouble. So I think, like you said, choosing the right patient is very important.
Dr. Malampalli, probably, if I may, I'm not pinpointing on the steroid indication part and all. I would leave it up to my intensivist or pulmonologist or the hospitalist colleagues. But for a minute, let us say, if my patient went into the hospital with pneumonia, I would put them on, that would be malpractice, right? If they develop a blood clot, and if you're in the hospital, unless your patient is making those strides in the hallways and refuses anticoagulation, technically I am liable if I don't put them on prophylactic anticoagulation. So the way that
I'm talking about
outpatient.
I mean, not mild cases who are not requiring oxygen.
As I
did write outpatient initially, and then I deleted it because there was another question in regards to be it inpatient or outpatient. But for people who are at home.
Right. No, I think then it makes a valid consideration. Again, I'm totally baffled sometimes when I see the list of doxycycline, you name it, boom, 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 all those things. It's like, I think with no due, no disrespect at all, but it is, I think it is helping the physician feel better because they're trying their best to help their patients and with no malintention, they're trying to help. And because they do not know how else, they think, let me not deprive my patient of this is probably the intent part. No, but if it is an outpatient thing, mild case and all, yeah, I think we would want to think twice. Yeah.
Right. Yeah, I think also the counseling the patient in regards to what to watch for if they are really concerned that they are at a high risk for clot or something, the counseling part is missing, or follow up and close monitoring of their symptoms and those kind of things. I've been doing these phone consultations with a lot of my family and friends, so I know what kind of prescriptions people are getting. Like Dr. Kairam also had a personal experience. So again, like I said, there's nothing, no pointing about like any of our colleagues over there, and because they are really doing all the hard work. And yeah,
they are. No question about it. Kudos to them.
Well, now that you mentioned Dr. Kairam's experience, my patient in Hyderabad, after 21 days of steroids, relatively high dose, was sent home yesterday to taper off another 10 days. He never needed oxygen. I completely failed communicating with them, convincing them to let him go home. They were so affected by cough. And somebody who could sleep 6-7 hours, whose respiratory rate is 18, and who never needed oxygen, has been given prescriptions containing 14 different items on a long sheet. So I'm heartbroken. What can I do from so far? That's what originally what I meant was, obviously you are getting a lot of phone calls. You are seeing a lot of inappropriate therapies, prescribing outside the guidelines. But I was indicating within the anticoagulation arena, have you also seen violations? That's what, but you already answered that very good. Dr. Naveen put in a comment, very nice words on behalf of the treating doctors, Dr. Madhavi. Dr. Naveen, do not misunderstand. 99% of them are doing a great job. But there's a group of doctors who are not following any guidelines, sir. That is my lament. But she's very right. They are doing an incredible job given how bad the situation is. And so heartbreaking to see in the last couple of days, angry parents, patients beating up our doctors. I mean, there's nothing more shameful than that. But that's not an appropriate item. I don't have Dr. Sudhakar's permission to discuss that topic. Any other questions, please? If not, I am going to thank Dr. Gurusu for creating this presentation, her PowerPoint, her detailed questions and answers. And Dr. Sudhakar, it is for you to say goodbye.
Dr. Khair.
Yes, yes.
I think there was one question on the chart that was left unanswered. Somebody asked about post-COVID discharge, drug of choice and duration. Dr. Saumini, I think we discussed that. Okay.
Which drug would you give at discharge and for how long?
For these outpatient, right? I think this is what we discussed about the rivaroxaban.
Post-discharge, yeah.
Post-discharge. So before we break off, again, that would be my part. Half of me is an oncologist, half of me is a hematologist. I can't sleep tonight if I don't do justice to my oncology part. That doesn't mean I'll go on that, but I put in a couple of slides at some point. Again, Dr. Kairam, you can share with the audience part where, again, I do not know the audience here. Would they need that kind? Probably not. But just a little bit of the things about, what what do you do if your patient is on cancer treatment, the vaccine part, and what is for the stem cell transplant or CAR T, whatever, those kind of things. And I put in if a patient is on immunotherapy, so I put in those National Society guidelines part. Again, if somebody is interested in, as I said, as an oncologist, I cannot go to sleep tonight if I didn't do that. But
Right.
thank you, it was fun. Thank you.
Last comment there is a note on the chat box. Somebody saying, good evening, doctors know the protocols, but pharma guys influence more, unfortunate. This is a very big discussion in my mind and in my contact circles, but I'm not going to pick that up unless Dr. Sudhakar allows it.
Yeah, Ram Mohan, I think that's not the question that we need to answer, or we need to discuss. I think that will be too much of digressing from our intention. So that's not the intention with which we are supposed to discuss. That can be done as a private discussion and not on this forum.
Enough said. Thank you, sir. This is not next one is not really a anticoagulation question. I have a doubt about Bartinisib 4 milligram tablet. When administered, do we need to reduce steroid dosage? I don't think they are related. You want to answer that? Otherwise, I'll take it to Dr. Mallampalli also.
Well, I'm not as familiar. I know that it's a Janus kinase inhibitor treatment. Whether how much do we have to reduce the steroid? No, I do not know the answer to that. Again, I don't use the drug.
I don't think that has been said in the past. I would have noticed it by now. Dr. Mallampalli, do you know for sure? Do you have to reduce the steroids?
I don't know for sure, doctor, but I think the study that medicine was looked at was in patients whose steroids are contraindicated, and instead of the steroids, they used baricitinib. So I don't know whether they can be used together, but I don't really think so. At least in the study that they didn't use the steroids.
All right, Dr. Sudhakar, I'm going to again thank Dr. Madhavi for her time, and we'll call her back if this darn disease doesn't go away. Thank you, Madhavi, for your time. You could tell your daughters today you had 250 people listening to you tonight.
I will do. Thank you.
Okay, bye-bye. Thank you all. Oh, tomorrow night, Dr. Prem Kumar is going to have an extensive presentation, and he's been working on it for the last 2-3 days. So I want to make sure all of you reappear tomorrow night, same time. Thank you all. Bye-bye. Bye, Madhavi.